Thank you. And I am excited to be here today to talk about implementation science. It's a topic near and dear to my heart, and I'm really passionate about because I really feel like it is a tool that we can use as a profession of pharmacy to really help move the profession and practice-based transformation forward. So today I'm going to establish why we should be using implementation science in pharmacy practice and our practice-based research, talk about what implementation science is and what the core principles are, and then really illustrate using a case study how you would apply these principles in the real-world research project. So first, the need for implementation science in pharmacy practice and research. I went to the literature and I looked at some of our major journals and said, search for those with implementation in the title. And we get a lot that come up, actually, and so I just randomly selected some and read through them. And we have implementation of pharmacy services, implementation and evaluation of pharmacist-led electronic visit programs. We have implementation and impact of integrated electronic prior authorizations, medication therapy collaborative. We have it for stewardship, opioid stewardship, antibiotic stewardship. Really, the list goes on. But I'm sitting there, and while these are great articles that show the impact of pharmacy services and on the clinical impact for the patients, sometimes I'm left scratching my head and saying, but what was the magic or the miracle that occurred to get you from the service to the outcomes? And how can we describe that better so that I, when working with the partners in practice, can describe that implementation process well enough for those who want to replicate and scale this service that found great impact and results. And we call that in implementation science the black box of implementation. So you have the what that's pretty well described usually in the literature, you know, what that service or program or intervention was, and then magically we get the health outcomes. Maybe we describe a few of the strategies we use in the literature, but often we aren't really systematically describing the implementation process that occurred, which can really impact what those outcomes are. And unfortunately, when we look to the literature for some of our most effective or well thought of interventions like medication therapy management, when we review them through a systematic review across all the articles, we often see kind of inconclusive evidence because there's variation in how it was implemented and how it was described in the literature. So and even sometimes there's no description of what that black box is, which makes it hard when we do these types of systematic reviews. So why are we having these mixed results in pharmacy practice and in healthcare in general? Is often we start with even our what may be ill-defined at times. So we may not describe what the core components of the intervention are, or if we do, have we described them in enough detail so that they can be replicated and scaled? Can we evaluate whether their practitioners have fidelity to that patient care process? The context. Oftentimes we will take something that was really effective in one setting or one state, and we think that we can just take it off the shelf and put it right into a completely different context, and without taking those contextual factors into account. And sometimes that context is not receptive or has a lot of other priorities, or we want to implement a new pharmacy service at the same time that they're implementing a new EHR system or something else. Well, the priorities just aren't there, and often that would make the implementation effort fail. And so if we don't start evaluating the context, the readiness, then I think that we're going to continue to see mixed results sometimes, even if the intervention itself is really effective. We also, as a profession, really are kind of new to the implementation science space, and so some metrics that have been developed for other fields haven't been translated yet, but myself and colleagues have been working towards making more pharmacy centric implementation outcomes and measures that can be utilized. And I hope to talk a little bit more about that today. And then the implementation strategies themselves need to be proactive strategies that really try to address some of the barriers that you may have identified early on in the process. So if it's a new intervention that you're trying to scale across multiple pharmacists, and you want to make sure that they're all doing it consistently, you don't just do one training and then just assume that everyone does it consistently. You need to use proactive strategies such as doing a quality assurance check every quarter or something with looking at their clinical documentation, doing peer reviews and assessments around that, doing fidelity monitoring to make sure that they are adherent to that process or that intervention that you're implementing. So those are the things that you want to look at proactively, select proactively, to really decrease implementation variability. And ultimately, that implementation variability leads to potentially inconclusive health outcomes and could, if you don't measure some of these other things, lead to a way of how do you understand whether that service was not effective, or was it that you just didn't implement it well? So implementation science can really help illuminate that black box of implementation. So I've been saying it a lot, but what is it? It's the study and application of strategies that promote the systematic uptake of evidence-based interventions into routine practice, with ultimately, the need to improve the quality and effectiveness of health services and impact patient care. And some benefits that have been documented in the literature for using this is traditionally the statistics are that it takes 17 years to get a practice only being used 14% of the time. And so that's a long time to wait for a patient that needs a service to get that service that we know is effective. With the use of active implementation strategies and implementation science approach, we see that you can get 80% use after 3 years. And so utilizing these frameworks is a way that we can help drive practice change in a faster way and a more efficient. It also helps us monitor the quality of your implementation efforts so that you can understand whether or not, like I was mentioning, was the intervention effective or ineffective, or was it that you really just didn't implement it well and therefore you didn't see the outcomes that you expected it to. And lastly, it helps with replication, sustainability, scale up. If you aren't documenting it in a systematic way that others can take and use, then naturally replication is just more challenging. So if you look inside the illuminated black box of implementation, this is where really you get both what the outcome, or the what is, the evidence-based intervention, your program, your service, and then you start thinking of how. So how did you get that service into place? What strategies, those proactive strategies, did you utilize? And start measuring and well describing your how. And then you also want to not only measure your health outcomes distally, but also what implementation outcomes are there. So were you delivering that service with fidelity, which means were you adherent to that patient care process, that service, that intervention? How feasible do the providers find that service? It's really not very feasible. That may explain why you have really low adoption and why you really didn't see the outcomes that you thought you would. So these implementation outcomes are all really ways that you may want to measure because it could help explain your final results. And then obviously also we look at the service outcomes that we're more often to look at in pharmacy practice. I think anyways, the safety, effectiveness, equity, patient-centeredness, timeliness, I think is another important one. And then what we were talking about earlier was context. So context kind of surrounds the whole thing and should always be being taken into account when we're evaluating whether an evidence-based practice or intervention really even fits within the service model that we're trying to deliver it in. So the core components that I think you're starting to pick up on now of implementation science is that you have these frameworks that guide your implementation, may guide your selection of strategies, may guide your evaluation of your implementation process. You have the strategies themselves and selecting those implementation strategies. You have the implementation outcomes that you want to measure. And then ultimately, what are the research designs that you use when you're starting to evaluate your implementation research? So before I go into applying it to pharmacy practice, are there any questions on what that is? And please feel free to stop me throughout if you have any. Okay. Well, I do think it's still pretty conceptual and high level, so as we get into this case example, maybe it'll start making more sense, because ultimately all of the work we do is more on the applied side, and it's with our partners, which are practitioners in the field, our health systems who have a problem that they're trying to address. And so the theory helps guide what we do in practice, but the reason for doing the research is just to make sure that we are, improving patient care and moving services forward. Not so much to say, I'm going to create a new framework or model. So my colleague at UNC actually created this decision-making kind of guide, and I find it pretty helpful to thinking through in a practical way how to go about using implementation science within your practice or within your applied research with a practice-based partner. So you start by first understanding what your goal is, your project needs, what you want to work on, improve, what your problem is. And then once you have that in mind, you select your service or intervention strategy based off of that need, and then you need to put it in place. So you select your guiding implementation science framework. And often you also may select that framework based off of what stage you are in within the implementation process. So that partner may come to you really early on and say that they just have a patient population that is not performing well on their diabetes quality metrics, and they want your help to develop a service that'll help address that. That may be where they come to you, and that would be really when they're just in exploration and trying to figure it out. Or I often get approached a little bit later on, and they're like, we have something, we've hired all the people, and we're going to do it, and we did it, started yesterday, but now we need to know whether it's effective. That often is what is more often what happens than not, and sometimes then you have to say, okay, well, you're already in implementation, so what type of things do we need to be measuring at this part of the process, and what frameworks may better help guide at that point. Then once you have selected that framework to guide it, you really have the practice side and the implementation research side. The next step really is to guide or to select your implementation strategies that guide the implementation of your service into practice, and then you'll want to wrap around some research if you're doing research to see whether your implementation outcomes, that acceptability, feasibility, how is it being adopted, those types of things are what you'd want to look at, and thinking about some research designs to help you collect both that information plus the maybe health outcomes that you're interested in as well. So I'm going to walk us through this kind of in a stepwise process to go through a case study. So the first step is the project goal, the project needs. And the case study comes from a large integrated healthcare system that I'm working with. And they actually had a broader problem that 8% of their patient population was accounting for 50% of their cost. And they had a really complex patient population. They were homebound, advanced age, had polypharmacy, multiple comorbidities, a lot of psychosocial issues, and they said, they were really performing well. All their traditional models are considered kind of gold standard in across the nation, but clearly we're failing to address the needs of this really complex patient population. So they wanted to create a new service model at home for patients who were costing the system a lot, but weren't responding to the traditional models of care that were already in existence. So they came up with this at-home team that was going to go in and provide comprehensive care in the patient's home. And it was delivered across a state in 15 different counties, and they're broken up into 3 different regions. The team, really, this is just to show that it was a large team that they put into place. They hired all of these people, a regional medical director, which was your kind of attending physician. They had advanced practitioners. They had nurses going into the homes. They had social workers, dietitians, pharmacists, palliative care, behavioral health, all on the team. Most of the team that went into the home was either the physicians, the advanced practitioners, or the nurses themselves. And then pharmacists were one team member that were providing more telephonic assistance to both the team members as well as directly to the patient. And so the pharmacist role was both just information, education, acute management, some disease management. And one of the things that the system wanted to implement and had never done, not just in this program, but across the whole health system, they had never used comprehensive medication management. And so I was brought into the project to help advise with the implementation of CMM. And so CMM is really a patient-centered service that is done collaboratively with a healthcare team, and it helps you systematically review all of the patient's medications and identify medication therapy problems. You're looking at, indication, effectiveness, safety, and adherence issues, and then hoping to directly address those or work with the provider to address ones that they weren't able to directly implement through a collaborative practice agreement or others. And I show this pyramid here of how pharmacist services can optimize population health, because I want to just point out that CMM wasn't meant to be delivered for every single patient who was in this population. Pharmacists were doing all different types of preventative health, safe, accurate provision of medication, consults, supportive services, access services. But, at the very top of the pyramid, those really complex patients do need to be receiving kind of a comprehensive medication management service that really addresses those with multiple chronic diseases, polypharmacy. That really is targeted. So we know that patients who will benefit from CMM are these high-risk complex patients. And so when I came in, they had said, we identified our patient population, we identified our service, CMM, that we want to provide. I understood that it seemed like a great fit from a evidence-based practice addressing the needs of the problem they identified. And so the goal was to implement CMM as a new service for pharmacists to provide. And they wanted to know, since their pharmacists had never delivered this before, how do we ensure consistency in delivery of CMM across all the pharmacists? What strategies, implementation strategies, would it be most effective to implement CMM? And does CMM just as a service work in the health, impact the health outcomes? Do we see the outcomes that we expect to? And so some of the contextual factors that I thought were really important to understand was that there was this clear perceived need, a fit for CMM was in place. There was already leadership buy-in. They had made a huge investment because they had the infrastructure, and they also had hired all the staff, that you saw on that org chart, including 5 pharmacists to span the 3 different regions that they had in place. And everyone was kind of new, so they were just starting to work together and figure out how to deliver the entire at-home service as well as CMM itself. So now we understand the project needs, we have a purpose. What guiding framework can we utilize to help with this? And so really, implementation science framework is defined as a broad set of constructs that organize concepts for implementation science. And the literature shows that we have over 60 implementation science frameworks to choose from. So often what I hear from most is, I don't even know, I went to the, I'm sold, I think I, could really use implementation science, and now I've gone to the literature, I'm completely overwhelmed, and I don't know where to start. And so I think that that's why in a systematic review from one of my friends and colleagues, Jenny Bocci, who's at the University of Washington, found that in community pharmacy setting patient care services, only 22 of 237 articles used an implementation science framework to guide that. So I think we have a long way to go, and I'm hoping that this next slide will help you start conceptualizing and narrowing down what type of framework to select. So Nielsen came up with these categories to kind of guide your selection of implementation science frameworks. So there's 3 main categories of frameworks that exist in the implementation science space. You have determinants frameworks, so those frameworks help identify your factors, basically your facilitators and barriers of implementation, science and outcomes. What makes that potentially, like what barriers may you run into if you try to implement a service, what may help facilitate that implementation process. And so it's really a more exploratory framework that you would want to do early on before you start implementing. The process frameworks help describe or guide an implementation process. So once you've selected your service that you want to implement, you want a framework to help you say, this is how, like, here are the steps, here's the process of putting that into place. And then you have your evaluation framework. And that framework helps you just evaluate your implementation and whether it was effective, whether you got the implementation outcomes that you wanted to see, whether you got the clinical outcomes that you wanted to see. And I put some examples of some common ones there, but there are many to choose from. And I also will just say from an applied perspective, often I kind of can pick and choose, right, from some of these and see their best practices. And I think that that's where the implementation researchers kind of deviate from when you start getting to more applied research and applied practice-based research. You want to get a service into place so that the patients can benefit, and so sometimes you use the tools that you have at hand, and it may not just be one framework. But given this, I wanted you guys to think to our case example and what category of framework applies best, you think, to our process, to this project. So why don't you take 1 minute at your table and think about what you would choose. Okay. So, I know we have some people remote too. What, we'll do a raise of hands. Who did a process framework? or selected that? Okay. Who did B, a determinants framework? Okay. Who did C, an evaluation framework? Okay.
You picked two.
You picked two? Yeah. Process? I'm hearing that. So I selected a process framework for this project because we already had identified some of the barriers and facilitators. We were already pretty much moving into implementation. They had hired all the staff. They had selected the intervention. And the determinants are really, I think, more helpful earlier in your implementation process of identifying various facilitators, maybe helping with the selection of the intervention itself. However, all of these can be applied to your any project, right? So sometimes you need to use all three types of these. And you'll even see that we did do evaluation. So ultimately, we did not use the re-aim framework, but we did use an evaluation, more of a program evaluation of this service. So, but for the purposes of walking through this case, I think the most relevant one was understanding just what was my process framework, how does that guide how to get CMM into practice. And so the EPIS framework is the one that I selected for this particular project. It stands for the Exploration, Preparation, Implementation, and Sustainment framework, and it really is a little self-explanatory by walking you through the different phases of implementation, with the recognition that it's not as linear as it looks, right? Implementation can be messy, it can go back, it can go forward. You're not always at one place at one time. But it does help you at least guide you, and you know where to kind of maybe concentrate your efforts. For example, the exploration phase, I came in after we had already evaluated the needs of that patient population, and they had already selected a potential evidence-based practice, CMM, and decided to adopt it. So in September 2018, I was brought on more in that preparation phase where they were planning on going live with CMM as a new service. They needed to do training and coaching. They needed to understand the implementation, how to evaluate the implementation, and then ultimately they wanted to hopefully get to sustainment phase. This framework also looks at the different contexts, so both the external contexts such as policy or other things that are going on outside of the organization, and then it also looks at internal context, so what you should be doing on a local level to put this practice into place. So given this, we've now selected our guiding framework, and we know our implementation stage or phase that we're in. We're in preparation in September 2018. And so we needed to select our implementation strategies to help put CMM into practice. So what are implementation strategies? These are just methods by which you can increase adoption, implementation, and sustainment. And Byron Powell, who recently left UNC, was the author who came up with the ERIC project. That helped identify 73 common strategies that have been described in the literature, not just in pharmacy, but across health and human services. And so that gives you a good starting place on where you may want to look, but then you also want to think specifically to what type of barriers and facilitators or areas of weakness do you have, and then look to the literature to see whether those particular strategies have showed evidence to increase an impact on that implementation process. And the same thing is you'll also want to look at the implementation stage, probably would guide some of the strategies you employ over time. And as always in implementation, you really need to tailor your strategies as well as your intervention to the local context. So what may have worked in one setting probably needs to be adapted for your work within your health system, within a new state, within whatever that may be. So one size doesn't really always fit all. So this slide is really to give you examples of what implementation strategies look like, and by phase, maybe how you would utilize them. Because implementation strategies probably are pretty common sense to us. In some ways, I think all of us have used an implementation strategy to put something in place. But we may not have systematically identified the need, selected that strategy to address that need, and then employed that strategy and measured whether some of those strategies were more effective than others. And so in that same systematic review by Bachi and her colleagues, she found that implicitly within the community pharmacy literature, on average, people used 6.5 implementation strategies to put something in place. So we weren't explicitly naming them in a lot of our literature, but we were implicitly at least describing some of these similar strategies. So example within the exploration phase of what an implementation strategy would look like would be conducting a needs assessment, a resource assessment, understanding whether your service that you selected or your evidence-based practice, like CMM, is a good fit to address that need that you've identified, making sure that it is a usable innovation, and what we mean by that is well described enough so that others can replicate and scale. Your team, identifying who your implementation team will be. I think that this is a really important step and often overlooked because it's great. A champion is another strategy, but a team I think is even more important because the team, say your champion leaves and only one person is implementing that. Well, what usually happens? Who here practices and has seen someone champion a service, they deliver the service, nobody else is part of the service, and then they leave. Oftentimes, it leaves with them, right? So having a team in place who's bought into this, has knowledge of how to deliver that service, ensures more sustainability in the long run. Readiness is another important but often overlooked step in the exploration phase. And readiness is really evaluating someone's commitment and then capacity to deliver an intervention or service. And capacity both at the organization level and capacity at the individual level for that. One study that looked at large scale change efforts, they looked at those change efforts that had failed, 50% could be attributed to a lack of readiness. So if you could do a few things I would always do the team and assessing your readiness. But unfortunately, I was brought in a little bit after this step, but sometimes you can convince people to go backwards. And then obviously you need buy-in from leadership. These are just examples of what you could do in exploration. Like I said, there's 73 different ones out there. I'm sure there's combinations that you could use. In preparation, you start to build that accountable team. You acquire your resources that you need, develop those measurement strategies so that you can start measuring when you put it into place. Like, is this working? Are people being seen? Are we getting the outcomes that we think? You need to probably change your record system. So you've never delivered this before. How are you going to document it? How are you going to be notified that patients need this service? Develop educational training material. And then once you get into implementation, you're delivering it, and you want to make sure, am I doing it consistently across all 5 pharmacists? Am I doing it with quality? Is it being adopted? Is there ways that we need to improve upon CMM or adapt it more? So we may do some PDSA cycles to continuously improve what delivery of CMM looks like, and continue to assess ongoing support needs. You could do some audit and feedback through documentation review, and you could establish a learning collaborative, all as strategies to continue that process. Then ultimately, sustainment is you have maintained fidelity. You have, ongoing training, maybe yearly, to account for those who come in and out of a program. You have identified sustainable funding source for it, and you're able to maybe scale to other organizations or to other areas within your organization or other organizations. So those are some examples. My next exercise is, based off of that, what implementation strategies would you have selected for the at-home project? So get back in your groups and take a second I'll put it back on this slide. This just is some strategies, but you could select something that's not on here as well. So come up with a few strategies you would employ. Who wants to just name a strategy that you thought of? Are y'all ready? What would you guys have done?
We chose evaluate implementation of quality and service.
Okay, great. That is one of the ones I selected. And anyone, what about you guys here at this table?
We said that we would look at the fidelity part so that everything is working towards that one goal.
Great. And so if you guys remember, one of our research questions was ensuring consistency across all of the practitioners. And so we also wanted to look at fidelity. So here are the 7 strategies that I selected with the research team and the clinical leadership within the organization. We decided to look back at their readiness, what was their commitment, their capacity to deliver CMM on top of all the other services that they were providing, had them build a team, and then we looked at developing and conducting a training program. Since they had never done CMM before, they did a pretty extensive training program by shadowing their other pharmacists who were doing disease state-specific training, but then they did all of the different diseases that they had protocols for, and then they did a week-long training with a external pharmacist that they brought in who had done CMM before and kind of did some standardized patients and stuff like that. We standardized the documentation so that everyone was documenting their CMM visits the same way. We also put smart data elements into that so that we could draw data back to help monitor their clinical outcomes, whether they were identifying medication therapy problems, other types of dashboards or other types of information that could be built into dashboards so that they could really monitor their progress. We did an audit and feedback for them where they had a quality assurance rubric for their notes, and the peers would evaluate each other. I'll talk about that a little bit more. We had a learning collaborative that was created. So these 5 pharmacists were across 3 different regions and often pretty much never talked to each other. So imagine how you can be inconsistent in how you're delivering this if you don't even talk to or know what your counterparts are doing in a completely different region. So once a quarter for a few hours in the afternoon, the pharmacists would get together in person. We would deliver some additional training around either motivational interviewing, how to document medication therapy problems, which came out of the quality assurance, this audit and feedback process. But then we also just gave them time to talk to each other about what was going well, what wasn't going well, what strategies had they tried to. One of their big barriers was that it was all telephonic based, and they had no one phone number when they called the patient. So patient couldn't really recognize who was calling. It was a 1-800 number, so you can imagine that the people actually cold calling, answering the phone was pretty low. So some of them started testing having their nurse that would go into the home be like, okay, like I'm going to schedule to call right after you leave, and the nurse would prompt and tell the patient to expect that call. And they saw more patients starting to pick up the phone, and so that had worked for one region, and they shared that at one of these learning collaboratives so that others could start trying to test these types of strategies that they were utilizing. And then before every quarterly in-person learning collaborative, they took a fidelity assessment, which is a self-reported basically survey that allowed them to say how often they were delivering this service as intended. And they got these scores back at the learning collaborative and got to discuss maybe why they hadn't met the marks that they thought they should. And so this just gives you an example of strategies, but I haven't really defined them well enough, right, so that you could go then and take this and then replicate it in a real world. And that's where the implementation science literature also provides us with a more structured framework for how to report these implementation science strategies. And this comes from Proctor and her colleagues. And she says that you need to report the actor, the action target, the dose, the temporality, and what implementation outcomes you're trying to affect. So I just took one of the strategies, but we did this for all of them to show you like what kind of detail is really helpful so others can take and replicate those strategies. So for the audit and feedback, why I called it audit and feedback is because in the literature, that's what is most often called. We had, within our collaborative, had called it a quality assurance chart review. But we selected to use the term audit and feedback because that really was what it was. And now when you search for audit and feedback in the literature, hopefully we start describing things all the same way instead of having to know what they called it in that health system. So this audit and feedback strategy was, the actor was the study team and the clinical leadership. And the action was that the documentation was created by the study team. We performed basically peer-reviewed pharmacist review of basically their CMM documentation. We discussed it because they were not based together, they would get together on WebEx and talk about what their feedback was to each other, where they could improve. They used this quality assurance rubric to review the whole note. It's not really there for you to be able to read the details, but they either marked it as exceptional, acceptable, needed improvement, not assessed, basically, or a teachable moment that sometimes then fed into those collaborative learning events. And then basically what we did for the whole reason for doing this was to ensure that they were documenting consistently, that they were also consistent within their patient care process, and they were able to start recognizing from their own peers areas of improvement, areas where they deviated. And so then we actually, one example being that their medication therapy problems, they were looking at the same problem and calling them different things. So one person would categorize switching to their COPD patients to their formulary for the triple, help me out guys, trilogy, right? Yeah. So most of them were saying, okay, I'm going to do that, and they would document that as adherence issue because it's more affordable. And then another person would be like, oh, ineffective therapy, needs additional therapy. And so as you can tell, like it was the same exact problem, but we're documenting it completely differently. So we had to do some more training around that as well. And ultimately, all of this was to improve fidelity as our implementation outcome. I put just another one up here to show how you would continue to document this in a way that could be replicated, but this is just how we standardize documentation. But for the sake of time, I'll just keep going. So the last step is to evaluate your implementation research and your practice, and you want to select your designs and the implementation outcomes that you're going to look at. And so this is just here to show first off that, at this point in the research and the translational pipeline, you're really on the far right side of things. You're, could a program work? Does the program work? Should have been probably demonstrated already. And now you're thinking about how to make that program work in the real world. And that's really what the implementation research is about. And I just wanted to point out, too, the differences between clinical research and the implementation research that I think are kind of a helpful distinction when thinking through a study and its features. So clinical research, I'm sure we're all familiar with. It's that clinical intervention. Your outcomes that you're interested in are the health outcomes, and the unit of analysis is usually the patient. Whereas in implementation research, you're really evaluating whether an implementation strategy worked, what impact it had on that implementation outcome that you were trying to target. So in that example where we were looking at the peer review process on the quality assurance, we were trying to improve fidelity. So we'd want to say, did we actually impact fidelity? And then the unit of analysis is we were looking at it on a pharmacist level, so per pharmacist. Or sometimes you would look at it on a clinic level if you have a large study across multiple clinics. And some of the just generic implementation research questions that often are asked is, how can we best translate the research evidence into usable knowledge for practice? What are some of the facilitators and barriers to implementing a new practice? What strategies are most effective, and what does it take to sustain and scale these interventions that have been found effective? And the research designs that we often utilize, some are your traditional ones. You may randomize different implementation strategies and see which ones work best. You may do comparative effectiveness. Some of the more creative ones are like step wedge or a SMART design. And sometimes non-randomized designs are also used. But I really wanted to just highlight one that I use most frequently in this, and it's the effectiveness implementation hybrid design. And this design looks at the spectrum of clinical effectiveness research to implementation research. And Curran and his colleagues came up with these 3 different types. First being you're really testing your clinical intervention, but you may want to start measuring observing more of your implementation indicators, whether that was feasible, whether adoption was high or low, maybe some fidelity data within that clinical effectiveness. And that would be earlier on in your translational pipeline. For this one, we looked at, for the case study that I'm describing, we looked at the clinical intervention effectiveness as well as we were testing implementation strategies and interventions. So that's something that you would design where you're looking both of these. And these are all decided a priori. And then lastly, you may want to start doing, like I was talking about, testing implementation strategies against each other to say, if I want to increase consistency, I'm going to compare this strategy with this strategy and see which one gives me better results. And so that would be your hybrid type 3 design. And then within those, I've been talking a lot about the implementation outcomes, and we saw it within that black box of implementation. But really, they're the indicators of implementation progress and success. And there are 8 core indicators that have been identified in the literature. And we have translated these as a survey for pharmacy practice. So it says, like, this service in a very pharmacy-specific language. So if anyone is interested in using those. It should be being published soon, but I'm also happy to share now because we want people to be utilizing them within their research and practice. But these are what they are. So adoption, appropriateness, acceptability, feasibility, fidelity, cost, and this is cost of implementation, penetration, and then sustainability. And we kind of have it here of different what stages are most helpful to think through those implementation outcomes and those definitions. But in general, I think that they're pretty intuitive. Did people start using that service or intervention? Was it perceived to be a good fit or relevant, compatible to the patient population? That's appropriateness. Was it, was it acceptable? Was it feasible? The fidelity, again, is that how were they delivering it as we intended for it to be delivered, and so on. So for this study, we already had defined our research questions, and I had mentioned we used the hybrid type 2 design to test both the clinical intervention and the implementation strategies itself. And we were measuring those implementation outcomes via survey and interviews with the pharmacist and the other team members to look at adoption, acceptability, appropriateness, and feasibility. And we were using the CMM self-assessment tool that I developed for measurement of fidelity. And then one of the things I didn't mention directly on here is we were also doing interviews to see what the perceived usefulness of the different implementation strategies were that we used. So our fidelity assessment, we see that we started to increase for the most part over time. We are still collecting some data, but the first one is the December, and it goes to the dark blue being December of 2019, so about a year's worth of data. And assess the information and formulate the medication therapy problem list, we actually see that dip because people thought that they were doing documenting medication therapy problems consistently, and then through their peer review process and the quality assurance, realized they weren't actually doing it, so you see it go down. And then as we did training, you see it go back up again. So some of the clinical outcomes, they looked at some of just who received CMM and how many medication therapy problems were identified. And then overall, the program that was not just pharmacy services, we're starting to show some pretty big impact for ED visits and hospital admissions. But this is still ongoing, so I don't have the full outcomes for you today. But with that, I'd be happy to take a few questions, and I think that just demonstrates how you apply implementation science to a practice-based problem you may have. Any questions?
Go back a couple slides.
Yeah, to the results, the graph. There you go. What do you think is going on with implementation of the care plan? There certainly was improvement there, but just out of the different measures, that piece seems to be kind of lagging behind. Yeah. Or maybe you don't know yet. But.
Well, anecdotally, I do. I'll tell you that our rates of acceptance for the changes that were being proposed were pretty low because it was a telephonically based service. They were able to implement about a third of the things, and then they would make recommendations to the providers. These providers that made up the team weren't comfortable making changes to something that a primary care or a specialist or someone else provided. So then they had to make a recommendation to somebody that they had no relationship with, and often those weren't resolved. So the implementation was actually quite low because of that.
At the beginning of your presentation,
Thanks.
All right. So in the beginning of your presentation, you mentioned that you were bringing other implementation science strategies to the pharmacy practice environment. So from what fields are you bringing other perspectives into how to implement pharmacy practice innovations?
Yeah, so I probably was referring to, so I've been, myself, colleagues have been taking already validated measures of implementation outcomes and other strategies, for example, but mainly let's stick with that implementation outcomes, right? These different outcomes, and we have looked to the implementation science literature. It could have come from mental health, it could have come from anywhere within pretty much the healthcare, health and human services, and those validated surveys were then adapted to pharmacy practice, and then we established the psychometric properties so that they would result in the outcomes that we expected. So now you can take that and apply it within a pharmacy-based setting. So that was one of the things I think hopefully we'll also get more learnings about some of these strategies and what is effective, may in one mental health setting may not be as effective in a community pharmacy setting. So starting to get some evidence on what strategies are effective